task. The next stage of artificial intelligence would be a general AI. What that means is it takes knowledge from one domain. So, for example, you train it in one domain,
Okay.
but it actually is able to use that knowledge in another domain. For example, you are aware that the fire is hot and it can burn your skin. The same knowledge, if you use when you're trying to burn something or you're trying to heat up something, that is transference of knowledge from one domain to the other domain. So AI can start doing that as a second stage. And the next stage of AI might be what is called a super AI, where AI basically outthinks a human, or it is able to think much faster, much better than humans. Now, let us look at some of the examples of narrow AI. If you believe that you are not exposed to AI or you do not use artificial intelligence in day to day life, then you are wrong. As a simple example is, if I were to plan for a trip to Goa today, I would go into my Google Maps and say, hey, tell me the fastest route to go to Goa from Bangalore on road. And Google Maps comes up with options for me. This is what is an AI is. It is thinking instead of me having to work out a lot of different permutation and combinations. It comes out and says, if you are going through Hubli, it will take you about 11 and a half hours. But if you decide to take a road through Hampi and Hospit, then it's going to take you 14 hours. So this is clearly telling me that use this route. This is going to be a better route. This is artificial intelligence. Another example is artificial intelligence, which is there in all of our phones. Every Android, Apple, or any other phones, Google phones that you have, everything has got virtual assistants within it. They are also examples of a simple artificial intelligence software. If you track the day to day activities of yours, you will realize that you are using AI from the time you have woken up till the time you're going to sleep. When you look at YouTube, you type in something and the computer suggests another option, which is again artificial intelligence. The computer is trained that if somebody is looking for, let us say, Goa, why don't you show them the hotels in Goa, or why don't you show them the restaurants in Goa? If somebody is searching for a movie ticket, why don't you show them a Uber or Ola ad so that they can go there in a cab? So these are all different types of artificial intelligence that we are all used to. Look at Google Maps, which I have just shown you. Look at the banking sector where the computer remembers your password. That is again artificial intelligence, and we have got used to these luxuries in our life. So yes, artificial intelligence is already there. We are using it on a daily basis. Some of it we are not aware of, some of it we are very well aware of. Now let's look at a different way of explaining what artificial intelligence is. Now let's look at a different way of explaining how artificial intelligence works. Let's say we're going to cook today and we have our mother, our wife, our sister who is an excellent cook, and we know that if you give her the right ingredients of dal, you give her the right ingredients of vegetables, and she knows from her experience, she knows from what she has been doing to give us a really tasty sambar or dal the way you prefer it. Now, this is what happens. Now, just imagine if your mother, your sister, or even your cook is not in a good mood, or is feeling she forgot something, or while they are cooking, they put something extra which is not their normal standard. You may get different varieties of the same sambar. Okay, if this is by purpose, that's fine. But if you were expecting the actual sambar that you like, but you got something different, then you start saying, why do we have to change? the samba that you usually cook is very tasty. I would have loved to have that samba. Now let's do the same cooking with our simple AI. Okay, let's say we are fortunate enough to have the super chitty as our computer, which has got all the knowledge, which has got artificial intelligence, and we give it the ingredients. We have given the ingredients, we keep the ingredients in front of it, and we draw up a algorithm. We tell the computer use this much of garam dal, use this much of brinjal, use this much of lady's finger or carrot. You write it all down. You let the water boil for 2 minutes at this temperature, and then you add this ingredient, and then you add that ingredient, and let it boil for 20 minutes. And then you will get your fantastic samba. With AI, which is a simple AI in this case, it will keep performing the same task without any variation, and you will get a continuously stable product or a stable samba. And this is the beauty of AI, because the computer is not going to get tired. The computer is not going to have a different mood today, or not going to be angry and put a little bit more masala in your samba, or put a little less salt in your samba. The output of this simple AI is going to be constant in there. And this is what has been happening so far. Okay, we teach a computer a very basic skill, we automate it, and it is able to keep doing it again and again. This is what we are seeing in our industries, where the machines are building different materials, and they are able to do that consistently to a specific quality. But that is not AI in the true sense. The AI now is advanced, and let's look at what it means. Now, when you see this image, you can see and realize that these are four different cats. Okay. But if the AI is presented with the same question and we tell the AI, please tell us, is this a cat or not? Okay, just looking at these images, AI is not going to be able to tell us. What we need to do is what is called as feature identification. So one level of AI is where we show the AI tool, we mark the tail and say there is a tail here, there are ears of this shape, there are paws or claws, and there are these whiskers that you can see. You input this data into the AI system, and then the AI system learns it, and next time it sees an image of a cat, it is able to recognize it. Similarly, if you give it a picture of a car and you tell the different features of a car, you tell it this is the windshield, this is the tire, this is how a car looks, the AI system learns it. Okay, it is able to extract those features that you have shown it is able to classify it internally, and it's able to come out and say, yep, this is car, or no, this is not car. This is what is called as machine learning, whereby we are teaching the machine that these features, if you see, then you can call this as a cat, or you can call this as a car. Now, we've had further progression. We've advanced further, whereby we are not looking at features, but we are looking at data. What does that mean? Instead of showing the machine cat pictures with showing its features, what you can do is show it thousands and millions of data and say, all these images are cats, all these images are bird, all these images are dog, all these images are frog. Now go and learn yourselves. Okay. The system keeps looking at all the images of cats, and it has a neural network that we have built inside it, where the machine starts to learn on its own. For example, if you show a child a cat first time and say, this is a cat, and next time the child sees it and says, yeah, this is a cat, you don't know what the child actually learned, whether the child saw the eyes of the cat and said, okay, anything which has an eye like that, I will call a cat, or whether anything with a tail, I will call a cat. So this is what is in artificial intelligence term called as the deep neuronal learning, which is a highly advanced way of machine learning. And this is what is become available in the last 5 years, and this is transforming the way artificial intelligence works. So, in a superficial manner, if you look at it, artificial intelligence is the larger group whereby you're training computers. Within that, there is machine learning, whereby we are giving the data to the machine and we are pointing out the features within the data for the machine to learn. The next level, which is the deep learning, is where we are just giving the data to the machine. We are not teaching it anything, but we are showing it the end results. For example, in the Chitty robot case, if you give the machine just the ingredients and you're giving it the masalas, you're not telling the machine anything at all, but you're just telling the machine, this is what I want you to produce. It is the machine's job to reach that point by its own permutation and combinations. Both machine learning and deep learning gets much better as more and more data keeps flowing into the system. Let us look at a clinical example to make it more simple for you to understand. So this is a CT brain of a patient, and you can see that there is hemorrhage or there is bleeding into the brain. Now, what we can do is we can mark this area and say this is hemorrhage and give similar thousands and thousands of images by marking into the computer system for it to learn that this is hemorrhage. That kind of learning is called as machine learning. On the other hand, if we take off all the annotations and we just tell the machine this is the image and there is hemorrhage in here. Where is the hemorrhage? We are not marking it. So the machine is looking at thousands and thousands of the same image and learning, okay, this is what hemorrhage looks like. This is called deep neural network. So we have seen what is artificial intelligence, and we have also seen the different levels of artificial intelligence and seen how it works. Now it is time to look at what can artificial intelligence do in the field of radiography currently. If you look at the job of a radiographer, you have job which is to identify the patient correctly, make sure that you're doing the right examination for the patient, then you plan for the examination, you position the patient in the right place, you then start looking at your CT or your MR, you're planning the procedure. Next, you're acquiring the images, you're exposing the patient to radiation, you are planning the MRI sequences, and you're acquiring the data. And finally, you're doing post processing. So these are the four major components of your day to day work. Now, let's look and see how artificial intelligence is already there or can help you in doing this work. On an X-ray platform, if you look at this data, there is a automated exposure control, there is a automated improvement of the image, there is also a automated positioning of the image or rotation of the image to get the best quality, which is already present in a lot of your digital radiography systems. Irrespective of the vendor, you will find that you have some form of an artificial intelligence system available to enhance the image that you have already acquired. Let's look at this example of an MRI. One of the major challenges often is a patient who is moving or keeps changing their head position and you're not able to get good quality images. Also, you have to angulate and plan your sequences when you're doing MRI. Now, with artificial intelligence, it is possible that the machine itself will acquire some data and then it can plan automatically the correct plane so people who are less experienced can actually do the scan and save a lot of time in the machine. Similarly, you can see here if you've got a pathology which distorts the anatomy, you are not able to clearly see the midline of the brain in this case, which has got a tumor. And then if you're going to plan your sequences, it becomes very hard. But AI can plan all of these sequences for you with just a click of button. I've shown you examples of a brain, and you may think, well, this is easy. It doesn't need much expertise. Anybody can do this. On the other hand, cardiac MR, for example, is a very complex procedure. And when you're doing this, you need to be well trained to get good quality data sets when you are doing a cardiac MR. But there is technology available now which can actually do the entire cardiac scan on its own if you just point out four specific points in the heart. So you start the scan, you do your localizers, and if you just go through some questions and say, point where the heart is, point where the mitral valve is, point where the left ventricular apex is, and the machine does the entire planning, and the machine can scan the patient on its own as well. So this is something very, very exciting. This is something very, very useful, especially in places where these examinations are not that common or the technician is not that well trained to perform these examinations. Let me show you another example. This is again very specific to CT and cardiac. Uh, the heart keeps moving, so the coronary arteries are also moving. So when we are imaging the coronary arteries, some of the coronary arteries are moving so much that we will not be able to see them properly. As you can see in this image, there is so much of blurring that we are seeing. With artificial intelligence, we get what is called a snapshot freeze. And in that snapshot freeze, which is a technology very specific to GE machines, where you can actually get rid of that movement. And you can see the image again here. The right coronary artery, whatever movement blur was there, can be taken out of, and you will get beautiful images of the right coronary artery. If you think this is fantastic, there have been further advances where instead of just looking at the coronary arteries now, we can actually remove the blurring or motion related artifacts of the entire heart. So let's look at this image where you can see the entire heart is looking very blurred, and just by a click of a button, we can improve the quality of the images significantly. You can again see the right coronary artery is blurred, and by just clicking one button, you are seeing that the entire image gets better. On the right hand side, you're seeing that aorta, which has got a stent in there. The amount of movement artifact is limiting the quality of study, and you apply this snapshot freeze, which is trained on artificial intelligence. It removes all movement artifacts. So you can see your planning, your acquisition, and even post processing is significantly improved or helped with artificial intelligence. Now, there is also a newer technology which is available, which is going to make your images look even more better at very low radiation. You can see in this example where a patient with a BMI of 62 is getting far superior image quality based on the newer technology, which is artificial intelligence based, even at a much lower dose. So if you look on the left hand side, a filter back projection, which we used to do in past, and now where we do iterative reconstruction, the images are very, very grainy because the patient is really fat. With the artificial intelligence, the post processing becomes even more superior and even more crisper, and we can see this beautiful image quality. So, knowing all of this, you start thinking, should I relax or should I really worry? Is my job in danger? Should I really be looking for a job change, or should I just relax and say, hey, this is not going to happen to me? I am not replaceable as far as radiography is concerned. There is certainly a threat, okay? With artificial intelligence, what is likely to happen is the radiographers are going to get more and more efficient. By that, a job which needed three radiographers now could be perhaps done by two radiographers. So your job is going to get automated, and as the automation happens, your job is going to get faster. And because it becomes faster, you may not need that many radiographers to do the job. The other way of also looking at it is the highly qualified people may not be required to do the technologist job. You could have somebody with basic degree who understands radiation protection and who understands how x-rays work can perhaps start doing all the work because machines are actually assisting that person in doing the job. It may also come up that you just have to position a patient or a nurse just positions a patient and the machine does the entire scanning in future. Reconstruction and printing of images may also become obsolete in future because everything might go digital and the machines may themselves be able to reconstruct the data. So you start saying, oh dear, this must be a very big headache for me. I have to start worrying about it. Or some of you say, hey, this is all in presentations, doesn't happen in real life. Let me show you what is already out there. There is technology which has been approved by the FDA of US and it is being clinically practiced is the use of artificial intelligence in reporting CT scans or picking up major pathologies in CT scans. It is also available to pick up fractures, especially wrist fractures, neck or femur fractures. Also, it can pick up pneumothorax or lung nodules and masses on a chest x-ray. It is also available to detect pulmonary embolism in CT pulmonary angiogram and also look at vertebral body fractures in a lot of patients. So AI is already being used in radiology, lesser for the technologists, but more for the radiologists. Would you like to see any opportunity coming out of it? I am an optimist. I personally believe that AI is going to make our life much better and AI is going to come and be part of our life. So there is no sense in fighting AI, but I think you need to partner with AI and you need to incorporate it in your day to day life and then you become better. For example, every tech will become a super tech because the quality of images that you're going to be producing with AI assistant is going to be fantastic. It also means that you're going to become super efficient. You're going to be able to do the task which takes you 2 hours, you'll be probably doing it in 1 hour time. So that will give you more time and you will become more productive, which may mean that your salary increases, your demand increases, and also, you may be able to work sitting at home remotely, providing your services to multiple diagnostic centers or multiple hospitals because the technology is available. The other thing which I would like to concentrate on newer roles. Okay, this is something very, very important, and you really need to think about this and start planning your career for future. What is happening in the Western world is the radiologists are not reporting radiographs. The x-rays are not reported by radiologists, but senior technologists or radiographers are trained to report x-rays for them. Similarly, ultrasound scans are not performed by radiologists, they are performed by sonographer or technologists who are trained in sonography. With artificial intelligence, this all job transition is going to get much more common and much more easier. For example, if you look at the x-rays which are done in an orthopedic hospital, radiologists do not often report these x-rays. If artificial intelligence is able to achieve 90%, 95% accuracy, and a reporting radiographer oversees the operation, then it is cheap for an institute. It will allow the radiologist to concentrate on more complex pathologies or interventions that they would like to do. So the radiographers kind of get a promotion. You become a reporting radiographers. You can start doing ultrasound scans because AI will assist you in doing that, or it will open up new horizons for you as you start to adopt AI. Also, think in terms of who is training AI and how is AI getting trained. The artificial intelligence systems, the machine learning systems are getting trained by people marking pathologies. So I am part of a couple of artificial intelligence groups. One such group is Predible, who I've been consulting for, and we've always looked for technicians to help us in annotating data. So you look at a brain CT and you see the hemorrhage, but we want to train the artificial intelligence that this is hemorrhage. So we need somebody to annotate the data for us. So that could be a radiographer who is good at looking at the images, because the radiologists may not be interested in doing this, and they may not be happy to do it at a cost which the radiographers are happy to perform. So you could become an AI enabler coming in future. So think and plan for your future, because AI is here to stay, and it is useful for you to get ahead of the curve and start becoming part of this new age. One final thing that I would like to tell you, maybe it is a um, futuristic thing, but I want to be very transparent. So far, whatever I have spoken about is just the narrow AI. I haven't even touched about the general AI or the super AI that one can see. These are some of the predictions. If you look by 2040, in another 20 years, we expect the general artificial intelligence to be built, whereby the computers will be able to do most of the tasks that humans are able to do. Something like driving a car on their own, something like reporting a study or performing a scan fully. By another 10, 15 years, we are probably going to look at super AI, where the computers are going to get much better than human beings, and we don't know how that future will look. So be prepared, be part of this transition process is what is important. In summary, AI is just like training a child. If you show something to a child again and again, the child learns from experience and starts to recognize those things. AI is very similar to that. It's just a machine which has got very good processing capacity and is able to learn. Also, AI is already accepted everywhere. So there is no sense in fighting AI or refusing to adopt AI. Be an early adopter, be an early enabler, because this will keep you far ahead of your competitors or your colleagues. Lot of technologist work can be replaced and can be made faster by AI. So you have to remain skilled, you have to be very good in what you do. This way, the AI will enhance your capabilities even further.
And finally, I would like to say it again that it is time to accept AI as part of our life and plan accordingly. Become an AI enabler rather than somebody who is blocking AI every time you come across it, because it is the future and it is here to stay. Thank you very much for your patient listening.
Thank you, sir, and thank you, Shashi.
Yeah, thank you so much due to the commitment. is was not available in the live session, but still he put effort to send a video to us. But especially he addressed in the beginning uh, Indian Society of Radiographers and Technologists doing a lot of educational activities, as well as he thanked all the member and as well as the Anto sir for hosting this program. With this, uh, we will end the today's guest speaker session, and we can move ahead with the today's oral presentation for the staff session. I think all the judges are already present. I welcome once again Mukesh Jain from SMS Medical College from Jaipur. Namaste, sir. Good afternoon. Along with that, we have Mohit Kumar Pandey. He's a lecturer from Goa Medical College. I welcome you, sir.
Yeah, thank you so much, Shashi. Thanks for inviting.
Yeah. Along with that, we have one more judges of the day. We have Vishwanath Nayak. He's a lecturer in City Paramedical College from Mangalore. And I welcome you, Vishwanath Nayak, sir. With this, I think we can go ahead with the today's presentation. It just already I have scored. I have shared the marks list along with you through email. Please go through that. If I will announce the participant name, then you can score accordingly. By the it's already distributed marks list is provided in marks score. If any doubt is there, you can be asked.
Yeah, Shashi sir, I received the marks list, and thank you for the opportunity provided to me. And I'll try to level best.
Thank you, sir. Thank you so much for, despite of, I know that you were a busy schedule, you joined with us and from a far place. Thank you so much, sir, for accepting our invitation. All the judges, please note that each oral session will be given 10 minutes. And after that, maybe discussion or suggestions will be welcomed by all the three judges. During the, if that any participant crosses the 10 minutes, I will put a buzzer sound from my side, and that will create you can eligible to give a negative mark for the crossing the time limit. So we have today's presenter. I think we're supposed to join Siddesh since it was given a 4 o'clock time. Since our today's guest speaker session is ended a little early, I think we have a Sirisha. Sirisha?
Yes, sir.
Yeah.
Good evening, sir.
Good evening. Good evening. We have Sirisha from the Divisional Railway Hospital. He's going to talk about the trending techniques in radiology. I request Sirisha to upload your PowerPoint presentation.
Yes, sir.
Sirisha, can you ask the mute your TV or something background, the background music?
Yes, sir.
It's fine now. Your time starts now. You can go ahead.
Good evening to one and all. Myself Shirisha Ji, radiologic technologist from Indian Railway Hospital, Bangalore. Today my topic is trending technologies in radiology. To start with, the radiology is being known as the heart of our modern healthcare. It helps us to provide deeper and more insightful information. It always aims to have new innovations to diagnose and give the best results for the patient. Few such innovations are hybrid imaging, virtual reality, 3D visualization, artificial intelligence, augmented reality, cryogen free MRI scanners, and blockchain. Hybrid imaging. The introduction of hybrid imaging systems like PET-CT, PET-MRI, SPECT-CT have given a very good advantage to our field, especially in the field of nuclear medicine in the prevalence of oncology. The ability of acquiring both anatomical and physiological information simultaneously is reducing the radiation dose given to the patient and also improves the better resolution of an image. It gives the more comprehensive diagnosis of the patient. This is a scan where a prostate cancer which has reoccurred is scanned in PET MRI, where the highlights are better visualized in PET MRI. And the below one is a scan where scintigraphy and SPECT-CT are compared. The intervertebral lesions are better visualized in SPECT-CT. Artificial intelligence. This includes the analytics and algorithms programmed in the systems. Example like Google's DeepMind helps us to read the 3D octascans with 99% accuracy. iCat's Profound AI is used as a solution for 3D mammography to view each layer of breast tissue and detect cancer. AI has become a supplemental lens for the medical image analysis. It helps us to optimize the protocols, hence less radiation. It enhances the noisy images and helps in the quantitative assessment of the scan. In this season of COVID-19, AI has played an important role in identifying the level of infection in the lung fields and hence giving us the percentage of how much the lung is infected and helps us to grade accordingly in the numbers ranging from 1 to 25. Very small lesions and very small EDHs are easily identified by AI, which are overseen by the people. Augmented reality and virtual reality. These are the computerized technologies with virtual reality where we feel the reality but in absence of person. 3D visualization. Now the radiology is becoming most dependently on 3D. It helps us in giving the cinematic rendering of a picture. It improves the confidence of people in pre-surgical planning. Hence, there are more surgical outcomes successful. It helps in 3D mammography by capturing the images at multiple angles and displays the tissues at various depths. This is an image where the vasculars are mapped and aneurysm is better identified in 3D image. Ultrasound image where the endometrial polyps are identified. 3D tomography enhances the very small lesion that can be overseen in 2D. 3D printing, it's an upcoming technology where the resins made up of liquid polymers and photosensitive molecules are dissolved in oxygen. These form the crosslinks to transform the resin from liquid to solid. It helps in better understanding of complex conditions like congenital heart diseases. It eases the interventional planning. It improves in the surgical outcomes, and even phantoms are produced using these resins. These are the 3D printers. A CT scan image is converted into dichrome 3D image and which is printed using the resin. It helps in the better planning of a surgery, and surgery outcomes are more successful than before. Data sharing. It is a technology where it includes PACS and a blockchain technology which uses the artificial intelligence. Examples are medical diagnostic web and deep radiology. These are the decentralized methods of data sharing where the imaging data are archived, distributed, and transferred to different departments as well as the healthcare center. It is very cost effective and secure platform which gives us easy access to data. The complete data from a radiology department or a hospital is sent to a software linked blockchain and which is converted into electronic health record, then to a cloud database where every person is given an access to the link with a unique keys. Only by entering those unique keys we can access, and hence it is a secure platform. Cryogen free preclinical MRI scanners. It is an upcoming scanner where the use of liquid helium is not there because of its scarce. We are planning for such MRI scanners. Presently, it is used for molecular imaging in researchers. It reduces both capital and running costs. Magnetic field can be varied. T power of magnet can be altered. And it is of lightweight, just of around 350 kgs, which was previously around 2 tons. It is used in the advancement of medicines and as a quantification tool for drug discovery. It plays a major role in toxicology. This is a cryogen-free MRI scanner presently used for researchers. And this is our existing clinical MRI scanner, which is 7 times heavier than the cryogen-free one. Here, the coolers which are inbuilt along with the superconducting coils are used to cool a very small amount of helium that is present in it, almost around 5 to 6 liters of helium, which was previously around 1500 liters in this clinical MRI. Conclusion: these upcoming innovative technologies have helped us in various ways, and it is very important for us to know about the updates in our field and make the best use of it. We can help in smoothening our workflow, optimizing the protocols, reducing the radiation delivered to the patient, improving the quality of diagnosis with the major accuracy, better surgical plannings and intervention plannings, easy access to data, and enhances the efficiency and operational excellence, improve our skills, and help us to give the better information and the best to the patients also. Thank you.
Yeah, thank you, Sirisha, for your wonderful presentation. Judges, if anything, suggestion or discussion on this regarding topic is open. And kindly note, all of you, all the judges, this candidate presented presentation within.
Shashi, may you please keep your speaker bit nearby to your face
Yes,
so that
sure.
yeah, you are not audible. Yes. Yeah. Yes, please.
Yeah, thank you, Sirisha.
Thank you.
Judges, please note that this candidate presented within the time limit. Anything suggestions, it is open to the judges.
Shirisha,
Yes, sir.
you explained about various techniques. Okay. I just want to know how much these techniques are helpful for common men. Are these
So by
affordable to
using,
them?
yes, sir, these techniques, especially like 3D imaging, they are seen in affordable prices. Instead of scanning a different series of sequences in a scan like MRI, we can take a 3D sequence, examine the patient, then give a better information just in a sequence. So it will be a bit of lesser cost in a scan as well as the reduced scan time.
Okay, fine.
Yeah, yes, Sirisha. Good afternoon.
Good afternoon, sir.
Yeah, I've seen your slide that PET CT is packed or the molecular hybrid imaging modalities. Is these associated with the reduced radiation doses? You mentioned
Yes, sir.
in your slide.
Sometimes because instead of using the standalone systems like PET as a separate scan and a CT as a separate scan, we can take an integrated system where a scan is done simultaneously at the same time. Hence, there is reduction in dose, and we get a better interpretation of the conclusions like diagnosis, like lesions are better visualized, which may be foreseen in CT alone or MRI alone.
No, if you go with the modality, these are the fusion of two modalities.
Yes, sir.
One, if we talked about the PET CT, once we are doing CT and it fused with the PET imaging. So we are doing dual imaging in this process. Once we are performing the CT as well as we are giving radionuclides and to perform the scan. So I think we had to re-estimate the radiation doses associated with the PET CT, and we need to re-escalate the literature. And the second thing, you tell that the scoring of CT in the COVID present scenario, it's done by the AI. So is it we started using AI in the COVID scanning, COVID scanning?
AI software, which is already included in the scanners, are helping us in better identification. So, like grading can be done much better when compared to us, the radiologist reporting it. Like few of the scanners are included with these softwares, but not all. But when it's included, we get a better accuracy in now COVID scannings, because very little infection can be overseen by the radiologist, which may not be
Yeah,
noted.
yeah, definitely. We have seen right now the Vimal sir presentation also.
So,
AI has the potential to like correct scanning, correct scoring in the city also. But as far as I think, till now we haven't started the use of AI in correct scoring. So just I want to know, just I wanted to know whether we started using or not. So thank you from my
it's
side.
been used in very little places, like very few of them have started with it, sir, but
Uh,
not all.
I think in India we haven't started
Yes,
still.
sir, yes. In general of radiology updates, I just took up with it also.
Okay, thank you.
Um, excuse me, can I interfere? This is Commander Daniel with you.
Yes, sir, good evening.
Mrs. Sashi Shetty ji, can I interfere for a minute? Good evening.
Shashi, you have to
Thank
mute
you,
your mic.
Dr. I'm very happy that you are joined with us and your talk was very nice.
Thank you, sir.
Already muted
Thank
my
you.
mic. I have answered. Hello. Hello.
Shashi, you
Yeah,
have
yeah,
to
we will give a
unmute.
time to you later, sir. We have, yeah, since
Hello.
we have today's guest speaker is already arrived. I mean, he's a live Vimal sir, Dr. Major Vimal sir is with us. Hello, sir. Good afternoon, sir.
Hi, good afternoon, team. How are you all?
Yes, sir. Thank you for your wonderful presentation. There was a very good presentation and listened by all our fraternity from the radiology department. And then
Thank you.
there was very good response in the YouTube as well. Maybe I feel from Africa, the other many countries from UAE and all, they responded very well. They liked your presentation. So thank you so much for accepting our invitation. And we had introduced you in the beginning, and we started playing your recorded video. Since I apologized with the these things, I request with you to have a few words about our program.
Thank you, Shashi. I would like to apologize that I am joining in from outside, so
Sir,
the audio
in the
might not be that great.
So it is very
I
clear.
would like to. Okay, excellent. Thank you. I would like to thank Anto and the society for giving me this opportunity to speak to all of you. Uh, it is a really auspicious occasion of 125 years of discovery of X-ray, and I'm really impressed with what the society has done for the last whole month of organizing such great academic topics, which is the need of the hour. So I would love to congratulate you guys and thank you again for the invitation. I am glad you all enjoyed it, and I hope I have managed to inspire a few people to kind of adopt AI a little bit earlier than what they may have done. And one thing which is very, very likely to happen is that AI is going to change the way we all work. And the sooner we get used to it, the sooner we adapt it in our day to day life, it will be useful. So, all the technologists, all the radiographers out there, I think it is the right time for you to start looking at your future career and become an AI enabler. And there are lots of opportunities. There are extremely great opportunities for all of you to become part of, and I'm sure it will be fantastic for all of you. Thank you once again for inviting me and giving me this opportunity to speak to all of you.
Thank you so much, sir. Since this is the fourth Sunday we are conducting program under the ISRT banner. We had a e-poster presentations with the different topics, and we had a quiz. There are about 900 students participating from all over India. And right now, we are into oral presentation for the staff. They are presenting in a different topics. Since I think the first presenter you heard that she talked about artificial intelligence related topics. Thank you so much for all the support to our field, and we heard a lot about you, sir. And with this, I thank you once again on behalf of ISRT, behalf of President and the General Secretary, and from the ANTO, sir. Thank you so much, sir.
Thanks a lot, Shashi.
Thank you,
Thank you
sir.
again, Ant.
Daniel, sir. Daniel, sir, is there?
No,
I
sir.
think he has logged out. Huh?
Yeah.
Shashi, I think you're on mute.
With this, we'll go ahead with the next oral presenter topic. We have next presenter, Chaitra Rajput. We have a next presenter, Chaitra Rajput. Okay, since maybe technical issue, I think we can go ahead with the next presenter. We have Alan VL
Yes, sir.
from Sri Gokulam. Yeah, Chaitra, are you there?
Yes, sir.
Yes, yes.
One
Yeah,
second, sir.
thank you so much.
Just a
We have
minute.
Chaitra Rajput from AIMS Bhopal. She's going to talk about basics of X-ray. I request Chaitra to upload your presentation.
So just a minute, sir.
you can present it. Okay, you are sharing this. Fine, fine. Can you unmute it yourself? I request Chaitra, can you unmute?
Chitra, you are not audible. Please unmute your mic. I think Shashi, if you have her contact number, you may just contact her and tell. I think she is not aware.
So,
Yeah.
Yeah.
Can,
Chitra, you are
so
not
can you hear
audible.
me?
yes.
So, good evening, everyone. I'm Mrs. Chitra Rajput, working as a radiographic technician at AIMS Bhopal, and I'm very pleased to be here to be presenting X-ray on basics of X-ray. This is the introduction. We will start with the introduction. An X-ray or X-radiation is a penetrating form of high-energy electromagnetic radiation. The first use of X-ray under clinical conditions by the John Hall Edward in Birmingham, England on 11 Jan 1896 when he radiographed a needle stuck in the hand of an associate. On Feb 14, 1896, Hall Edward was also the first use X-ray in a surgical operation. Next is the discovery of X-rays. All we are familiar with this, a great person in the late 1895, a German physicist, V.C. Roentgen, was working with a cathode ray tube similar to our fluorescent light bulbs. He temporarily termed X-rays X for something unknown. As achievement that he received a very first Nobel Prize in Physics in 1901. In 2004, the IUPAC named element atomic number 111 Roentgenium, having multiple unstable isotopes. He took a picture, a radiograph, using X-rays of his wife Anna Bertha's hand, as shown in this picture. He is awarded as honorary doctor of medicine. Roentgen published a total 3 papers on X-rays between 1895 1897. Roentgen is considered the father of diagnostic radiology. Next is hazard discovered. Till this, hazard were not known. With the widespread experimentation with X-rays after their discovery in 1895 by scientists, physicians, and inventors, came by many stories of burns, hair loss, births in technical journals of time. Eliot Thomson and Edison Lab deliberately exposed a finger to an X-ray tube over a swelling and bristling. Next, energy ranges. There are 2 types of X-rays, soft and hard X-rays. Hard X-rays are those having high photon energies above 5 to 10 kilo electron volt, below 0.2 to 0.1 nanometer wavelength. These are having high penetration, used to image the inside the body, example medical radiography and airport security. Hard X-rays are similar to the size of atoms. They are also useful for determining crystal structures by X-ray crystallography. Next is soft X-rays, and soft X-rays are those with lower energy and longer wavelength. Soft X-rays are easily absorbed in air. The attenuation length is 600 electron volt. Next is properties of an X-rays. X-ray photons carry enough energy to ionize atoms and disturb molecular bonds. Therefore, it is ionizing radiation. Here we can see a radiation hazard sign. These having high penetrating power causes fluorescence of certain crystal, liberate heat on passing through matter, and X-rays have much shorter wavelength than visible light, and they travel at the same speed of light, that is 3 into 10 to the power 8 meter per second. Most X-rays have wavelength ranging from 0.01 to 10 nanometer and frequency ranges from 3 into 10 to the power 16 hertz to 3 into 10 to the power 19 hertz, and energy in the ranges 100 electron volt to 100 kilo electron volt. It is interaction with matter. In diagnostic radiography, interaction always occur in orbital electron. There will be three possible fates away each photon. That is, first is penetration, second is absorption, third is scattering. And on this basis, there are 5 different processes by which X-ray may be observed or scattered as they pass through the medium. The first 3 of which play a role in diagnostic radiology, and
I think
Yeah, I think some technical maybe
might
interruption.
be.
Yes, the participant exited. It was a 5 minutes, 30 seconds. The candidate, which is time taken. I think we will give one more chance later.
Yeah.
Judges.
Yes, yes. This is a technical problem, so
Yes,
we may
yes.
consider that.
I think we can request the next participant, Mr. Allen, sir.
Yeah, hello, sir.
Allen,
Yeah,
yeah,
yeah, sir. Yeah,
yeah. I request you to carry over. Then later
yeah,
we
sir.
will give
Sure.
a chance to her.
Sure, sir.
We have next presenter, Alan VL, Sri Gokulam Medical College, from Sri Gokulam Medical College. I'm going to talk about AI in radiology for COVID diagnosis.
Sir, can
It's not yet seen.
okay, sir. It's uploading. Yes, sir. Now it's okay.
Yes, can you make it a full screen?
Yeah, sir. Sure. Okay, sir. Can I start?
Yeah, your start time
Okay.
starts now.
Okay. Good evening, all. My name is Alan VL. I am currently working as CT technologist at Jura Hospitals, Bangalore. Now, today I am going to present AI in radiology for COVID-19 diagnosis. Today, Vimal sir took a class about AI in radiology. Now, I am going to talk about AI for COVID-19 diagnosis. Okay, before get started, we have to know about the past, where we are now here. That is, X-ray was discovered by William Röntgen on November 8, 1895 in Germany. You can see in the left side the picture of an X-ray. It is his wife X-ray, which has a wedding ring on her hand, and on the right side, Sir William Röntgen sir is there. And first medical X-ray performed at John Hopkins in February 1896. You can see the earlier image of Hopkins Hospital on the left, and the equipments used there was on the right. And a lot has changed since then. In 1896, the first X-ray was taken to the, now we are here in 2020. A lot has changed. You can see that on the left side, the X-ray equipments used there is no safety measures, nothing, less safety measures are there. The X-ray equipments are not well prepared like that. And on the right side, you can see the techniques used now, you can see on the right. And radiation dose, we can tell about the radiation dose. At that time, no radiation safety measures, precautions or not. Now we are getting less radiation. On John Hopkins, a radiologist also and managing director in radiology also died with the radiation related issues. Now there is not such problems in that also changed. And at my time also the X-ray films technology we have to make so many procedures, that is washing, developing, everything we have to done. Now it is a digital imaging is here. I have to just expose, we can get the image on the spot. And you can see the soft tissue on the left side, and we can get the image of the neck X-ray, and we can see the less information. On the right side, you can see the virtual image of an CT scan. You can see the nerve, arteries, veins, everything on the right. You can see a lot of change. On CT scan performed in 1976. we get 35 to 40 exams per exam. 35 to 40 images per exam. On 2020, we are getting 3,000 to 4,000 images per exam. And what hasn't changed since we did our first X-ray since 1896? And what needs to change? Yeah, it is how a radiologist interprets an image. It is always same from that beginning to here. Even after 100 years, it is same. Because radiologists using visual acuity and search patterns to recognize an image. It is already based on training and experience. If more the radiologists see in an image, better the radiologists are. They are with their experience, they are finding abnormalities because it is a pattern recognition. And what problems we are facing is not all the information on an image is viewed because they are radiologists to every inch and every corner of an image which there is an abnormality which
Activity.
Hello.
SI unit is becquerel, conversion unit is curie, and 1 Q equals to 3.7 into 10 to the power 10 becquerel.
Hello.
Can you wait for?
Yes, sir.
Yeah, you were interrupted in between. You are exited. No, that's the reason we are requesting Alan to continue. After his presentation, we'll allow you to continue from your.
Okay, sir. Okay, sir. Let me know where I.
Others, please mute your mic and close your videos so that it will be clear to everyone.
Sir, can I
Other than the
continue?
presenter.
Hello, sir. Can I continue?
Yes, Alan, please continue.
Okay, it's not all information on an image is viewed because the radiologist can't see the every inch and every corner of an image because the distractions. Because when a radiologist interprets an image, his phone rings, and when someone enters into the reading room, the interruptions or distractions happen, and the experience varies. Experience is a vital factor in observing an image because if he is working in an organization or institution which so many cases are there, better the registrar or less they are interpreting, the radiologist not at all able to see the abnormalities, and high error rate as high as 30% in some images because they are not seeing the findings, misinterpreting, because if they see a tumor which is benign, they think that is a benign, but it is actually a malignant. That are the reasons happens. And we can go to the artificial intelligence. Nowadays, today also Dr. Vimal sir talked about artificial intelligence. So we can, artificial intelligence is not a new thing today because AI is more than 70 years old. It is already used in medicine. The series has been around since 1970s. Clinical support it's already in 1970s. You can see the list of early systems here. ASLPs there. ASL is the first computer clinical decision support system in 1972 in the United Kingdom. Computer likely cause of acute abdominal pain based on patient symptoms. Feeding the system with more symptoms and diagnostics helped it to become more accurate. Or in 1974, the system was more accurate at diagnosis than junior doctors and almost as accurate as the most senior consultants. It took AFL overnight to give a diagnosis, but in abdominal pain, it is too late to get the report. And artificial intelligence, it was the slow progress for decades, with the focus on relatively simple problems because it focused on recognition and image recognition. It took so long. 7 years ago, sudden leap in progress because the computer system has already increased in performance because nowadays, in 2020, Apple introduced its own chipset called M1, which is already well fastest processor. So the computer is increasing. When we go to machine learning comprises of a broad class of statistical analysis algorithm, iteratively improving response to training because it gives a algorithm data, which the data is known data, and it is used to predict labels on new data. It will learn automatically to predict new data, so we can get the result. When we compare artificial machine learning and deep learning, artificial intelligence is the broader category, and machine learning is the subcategory of artificial intelligence, and deep learning there is subcategory of machine learning. When we talk about intelligence, I can tell about the chess game we played in our school time. When we move, when do that move, do that is just artificial intelligence. We give the specific task, they will give us like that. And machine learning, ML approach to AI.
and we can use it to think about spam folder. If I get a mail, I tell the computer that it's a junk mail, it automatically move to the junk. When I get a similar mail that is similar to the previous mail, it already recognize that is a spam also. It will learn over time. Deep learning, we can compare it with the driverless car. DL is a technique for implementing machine learning inspired with a neural network in our brain that Dr. Vimal sir also talked about that huge neural network. It will like a car, it will know how to go, how to handle a situation like that. And now I am talking about AI COVID-19 diagnosis. COVID-19 diagnosis is virus SARS-CoV-2, gold standard reverse transcription polymerase chain reaction RT-PCR, and it has high sensitivity, but false negative rate is also high. Results can take up to 2 days because positive, it high chance of positive, but it is negative, but it may not be negative because several tests have to be done to sure that is true negative. So contagious early detection is crucial. This virus is contagious and fast detection must. And CT or X-ray imaging can play a critical role in diagnosis. And CT imaging used as a primary screening tool is currently discouraged by CDC. Typical finding ground glass opacity is bilateral, peripheral, and long lung distribution. Sometimes it's a rounded morphology. We can see the rounded morphology here, and air splice consolidation, reticular consolidation, crazy paving here, and halo sign in this image, halo sign is the and atypical findings such as pleural effusion, cavitation, pulmonary nodule, thoracic lymphadenopathy. And what we learn from CT imaging. CT imaging has unique features which can be recognized by radiologists. No CT in the early stages of COVID-19 patients, that's a big problem because no CT can be identified. Artificial intelligence role in fighting COVID-19 learn features from imaging, from radiology. AI combine imaging with the clinical information to make rapid and comprehensive diagnosis. You can see the framework full CT scan. We are having input model and output. We are having full CT scan as input and non-clinical information such as exposure settings, exposure work like that. And we will get a P1 as which can report P2 as clinical information and P3 as joint information. And conclusion. In this work, a generalized AI work combining imaging and clinical data was proposed to make rapid and comprehensive diagnosis of COVID-19. AI can achieve similar performance of senior radiologists, and the combined model has advantages to diagnose early stage patient normal CTs. Okay, thanks. Thank you for giving the chance to present the radiation. Thank you, sir.
Thank you, Alan. Judges, is over to you. Kindly note that this candidate was presented within the time limit.
Okay, Mr. Alan.
Yes, sir.
Yeah. Throughout your presentation, the way I understood with the topic was AI in radiology for COVID-19 diagnosis, right?
Yes, sir. Yes.
But what I expected was a bit different the way you have presented. I just want to know whether you can use this artificial intelligence at present for COVID-19 diagnosis.
Yes, sir. Nowadays it is using in US. I think it is using. It can be used in where with the AI developing nowadays. So it can be with the better programming. It can be used.
Okay, fine, fine.
We can give,
so what are your views? What are your views? Can this artificial intelligence give better results as compared to the diagnosis by a radiologist?
Sir, about 90 to 95% we can achieve with the AI, sir.
But not 100%.
But not 100%. It has to learn over time, sir. It maybe in more the result are giving to learn for AI will learn over time. It will take time to get 100%.
Okay. Is it actually useful technique, or it is just like we are overburdening COVID-19 with another term AI in COVID-19?
Sir, in the COVID-19 we need to get the results as soon as possible. In case of AI, if it is not, it is a negative case, it will give the result on the spot. So it is useful if we use it in the right way. And in normal cases, it will take up to 2 days or 3 days to get the report. If we implemented AI in COVID-19 diagnosis, is useful for us to get result.
Okay, one final question to you.
Yeah, sir.
Which type of diagnosis will you prefer in your hospital, AI or conventional radiologist based diagnosis?
Nowadays, conventional radiography based, but if AI can get achieve percent, we can replace AI with the conventional radiography.
Okay, fine, fine. You are expecting further more techniques to come,
Yeah.
technology to come and over just
Yes, sir.
superimpose the previous
Yeah.
techniques. Yeah.
Yes. Sir.
Okay. Okay. Thank you so much. It was a good presentation.
Okay. Thank you, sir. Thank you very much.
Hello.
Sir.
Uh, may I speak?
Thank you, sir.
Yeah.
Yes,
Yeah.
sir.
Good afternoon. Yeah.
Good afternoon, sir.
Good afternoon, Alan.
Yeah. Good afternoon, sir.
As Mohit sir also told that presentation, we supposed to have some data on the use of AI for the COVID. However, we get to know about the what is AI.
Artificial.
So yeah. So what you think? Why it's time of 40 years have taken as the AI is introduced in the 1917, and still we are trying to uh, rediscover the things. So what is the hindrance in your view?
Yes, sir. So, already it is 70 years old. It is used for medicines at that time, but
Yeah.
AI is completely different the computer systems. Now, last 7 years, a huge leap in computer system because the computer system, how the computer performance, the AI also improves. And nowadays, in 2020 also, nowadays Dell took the market for the processes, and nowadays Apple introduced its own first of
Okay.
its own processor.
It's the limitation of the processor where that we
Yeah.
don't have that kind of calculation of mathematical algorithm to do that. You told about the using of KI in the COVID.
Yes.
In present scenario, what you think that they using the AI algorithm trained a machine trained in a US or UK, and is it feasible to use the same machine or same training in India, or do you need or the specialized training for us for the Indian races to get
Yes.
the superior results?
Yes, sir. In India, the compared to US and Indian, every environment varies and the situation here varies because uh, not the transportation here is not there because we have to give the exposure controls, exposure settings in India. We have to give it to the AI. We have to make a separate algorithm, separate data for the AI for India. We can't implement the same as they are using there here because here in environment varies and the patient varies, conditions varies. They are getting contact from different that also varies. We have to implement the data which is relevant here. We have to give the AI the data which we
So
get from there. Yeah.
we need to train the machine in
Yeah. From
a
with
situation
here
also.
condition.
So okay. So and okay.
Thank you, sir.
Okay, thank you,
Yeah, Vishnu.
judges. Thank you, Ellen.
Thank
We'll
you,
go ahead
sir.
with the next presenter.
Okay.
We will give again chance for the Chitra Rajput. I request you to upload your presentation. Chitra, are you there? Can you unmute? You need to unmute.
Yes, sir.
Yeah, judges, please note that we will request the candidate to present representation. So since that, we will ask Chitra to present it from the beginning.
Okay.
Can you, Chitra, can you?
Sir,
Yes.
my name is Chitra Rajput, and I'm presenting a presentation on basic of X-rays. Here we start with the introduction. An X-ray or X-radiation is a penetrating form of high-energy electromagnetic radiation. The first use of X-ray under clinical conditions was by John Hall Edward in Birmingham, England on 11th Jan 1896 when he radiographed a needle stuck in the hand of an associate. On Feb 14, 1896, Hall Edward was also first used to X-rays in a surgical operation. Next, the discovery of X-rays. All we are familiar with this great man. In the late 1895, a German physicist V.C. Roentgen was working with a cathode ray tube, which was similar to our fluorescent light bulbs. He temporarily termed X-rays and X for something unknown. He doesn't know what was that. As achievement that earned him the very first Nobel Prize in Physics in 1901. In honor of his accomplishment, in 2004, the IUPAC named element having atomic number 111 Roentgenium, a radioactive element with multiple unstable isotopes. About 6 weeks after his discovery, he took a picture, a radiograph, using X-rays of his wife Anna Bhatta's hand, as shown in this figure. He awarded an honorary doctor of medicine. Roentgen published a total 3 papers on X-rays between 1895 to 1897. Roentgen is considered the father of diagnostic radiology. Hazard discovered. Till this, hazards were not known. With the widespread experimentation with X-rays after their discovery in 1895 by scientists, physicians, and inventors came many stories of burns, hair loss, worse in technical journals of the time. Elihu Thomson at Edison's lab deliberately exposed a finger to an X-ray tube over a swelling and bristling. Next is energy ranges. There are two types of X-rays, soft and hard X-rays. Hard X-rays are those with high photon energies above 5 to 10 kilo electron volt, below zero point 0.2 to zero point 0.1 nanometer wavelength are called hard X-rays. These are having high penetration used to image the inside the body. Example, medical radiography and airport security. Hard X-rays are similar to the size of atoms. They are also useful for determining crystal structures by X-ray crystallography. Next is soft X-rays. X-rays those with low energy means longer wavelength, right, are called soft X-rays. Soft X-rays are easily absorbed in air. The attenuation length is 600 electron volt. Next is properties of an X-rays. An X-ray photon carry enough energy to ionize atoms and disrupt molecular bonds. Therefore, it is ionizing radiation. Here we can see a radiation hazard sign. These are having high penetrating power, and X-ray causes fluorescence of certain crystal, and they liberate minute heat on passing through any matter. X-ray have much shorter wavelength than visible light. travel at the same speed of light, that is 3 into 10 to the power 8 meter per second. Most X-rays have wavelengths ranging from 0.01 to 10 nanometer. Frequency in the range 3 into 10 to the power 16 hertz and 3 into 10 to the power 19 hertz, and energy is ranges from 100 electron volt to 100 kilo electron volt. Next is interaction with matter. In diagnostic radiology, interaction always occur in orbital of electrons. There can be three possible fates awaits each photon. First is penetration, second is absorption, third is scattering. On this basis, there are 5 different processes by which X-ray may be absorbed or scattered as they pass through the medium. The first 3 of which play a role in diagnostic radiology and nuclear medicine. First is coherent scattering, second is photoelectric effect, third is Compton scattering, fourth is pair production, and fifth one is photo disintegration. First is coherent scattering, and this also known as Thomas Rayleigh classical and modified scattering. J.J. Thomson discovered classical scattering. It occurs when the energy of X-ray or gamma photon is smaller in relation to the ionizing energy of an atom. It therefore occurs with low energy radiation. The photon doesn't have enough energy to liberate the electrons from its bound state. So there will be no energy transfer and no ionization. Here you can see a photon interact with an atom having wavelength lambda, and atom get excited. After this, photon is released with the same wavelength. So therefore no energy transfer and there will be no ionization. Second is Compton scattering. It occurs due to the interaction of the photon with a free electron or loosely bound valence shell electron. The resultant incident photon is scattered and imparts energy to the electron, which is called recoil electron. Here you can see a photon of having 80 kilo electron volt scattered some energy, loses its energy, and eject an electron, which is called recoil electron, and is discovered by American physicist Arthur Compton. These are inelastic, non-classical, and incoherent scattering. And Compton scattering will always lead to scattered radiation. Next is photoelectric effect. Photoelectric effect is the one of the principal form of interaction of X-ray and gamma photons with matter. A photon interacts with an inner shell electron in the atom and removes it from its cell. Here, photon is interact with an electron and is eject electron. The ejected electron is called photoelectron. Photoelectric effect is always lead to subject contrast. It occurs when an incident photon has energy equals to or greater than binding energy. It accompanied by emission of characteristic radiation. Next is pair production. It doesn't occur in diagnostic radiology. Occur when a photon energy is greater than 1.02 mega electron volt. When a high photon energy is converted into matter into two particles. First is positron and second one is electron, having equal mass 0.51 mega electron volt, and it is used in PEG. Last one is photo disintegration. Occurs with energy greater than 10 mega electron volt. Part of nucleus is ejected by high energy photon. The ejected portion may be neutron, proton, alpha particles, or cluster of particles. Next is adverse effect. These are short-term side effects such as cancer, changes to DNA. It will lead to mutation. Bone absorbs radiation, and when bone absorbs radiation, it becomes brittle and can be broken easily. Exposure to high radiation, it can be dry mouth, vomiting, bleeding, fainting, hair loss, and loss of skin and hair. Last one is units. Units of measure and exposure. These are quantity we can take. First one is absorbed dose. Having SI unit is gray, conventional unit is red, and 1 red is equals to 0.01 gray. Activity SI unit is becquerel, conventional unit is curie, and 1 curie equals to 3.7 into 10 to the power 10 becquerel. Exposure SI unit is coulomb per kg, conventional unit is Roentgen, and 1 Roentgen equals to 2.58 into 10 to the power minus 4 coulomb per kg. And equivalent dose and effective dose having same SI unit Sievert, and conventional unit is REM, and REM is Roentgen equivalent man, and 1 rem equals to 0.01 sievert. Thank you.
Thank you, Chitra. Judges, please note this candidate present within the time limit. Discussion or suggestion is over to the judges.
Okay, good afternoon, Chitra, for the presentation.
Mukesh sir, can you switch on your camera? If you don't mind.
Yes, sir.
Yeah, because since it's a live, so when you are asking question in YouTube, it clicks only M name. M
Okay.
Thank you so much.
Sure, sir. I'll do for the next time also. Good afternoon, Chitra, for the presentation. In your presentation, you told that when X-rays interact with the body, it is liberating the heat. So, is there any studies do you refer that it's increase in body temperature while doing the radiography? Hello, Chitra. I think, sir, might be technically she left them. Yeah, we'll conduct question later on.
Later sessions.
Yes.
Next, we will have presenter Mr. Gajendra Sahu. Gajendra Sahu. Can you hear me? Meanwhile, Saroj, can you mute your mic, please? Saroj Thakur.
Yes, sir.
Can you mute your mic?
Yes, sir. Good evening, sir.
गजेंद्र.
Yes, sir.
आपका पीपीटी अपलोड कीजिए.
Hello, good evening, sir. It is my chance or Mr. Gajadhar chance? Who has to present?
गजेंद्र chance. But सरोज,
okay, sir.
आपका माइक थोड़ा म्यूट कीजिए.
Yeah, mic is mute.
Not mute.
Hello, sir. My name is Janan Sahu, Dugin Hospital, Kavardha. Presentation topic: City Head Protocol. Routine cerebral sequence.
Can you, Gajendra, can you upload your PPT?
No, sir. No problem, sir.
No, without PPT you can't present, sir.
switch off your camera and mute your mic. Other than the presenter, and because many candidates have switched on their mic, no?
No,
Mic
that is
and
fine, sir. Because in a YouTube live, only the one who speak, their
okay,
will be auto. Is auto this thing? It will come on live.
okay.
Yeah.
Chitra,
Yeah.
can you hear me? Chitra, madam, can you hear me?
Yes, sir.
Yeah. Mukesh sir, can please go ahead.
Yeah. Good afternoon, Chitra ji,
Yes, sir.
for the presentation. I saw in your presentation you told about the when X-rays interacted with equilibrated heat.
Yes, sir.
So I just want to know: is there any study to refer that consider putting the fact that when radiography is doing that, body temperature is increasing?
So the temperature increases at some flux reaches 55 Kelvin in air and far beyond the melting point temperature in vacuum. But we can use this in crystallography for of biological macromolecules. Radiation damage has been a problem, and
I'm asking that when X-rays interact with the human system or the biological system, is it liberating the heat? Because in your presentation you mentioned. I think, sir, she left.
Yeah, that's fine, sir. No problem. Again, we will not give again chance. I think this is
Yeah.
so many chances. I feel.
Yeah, might be. She's
Yeah, it was
left.
clearly given instruction, sir, in the beginning, and we had personally called each candidate. They had to be available with the PowerPoint presentation and with the proper
Yeah,
internet
sometimes
facility.
might be technical deficiency might be
Yeah.
there, so she won't
I
be
can
able.
agree. I can agree that, sir, because
Yeah.
it is internet. It is not easily available at the same
Yeah,
time
yeah.
every place.
Yeah, yeah.
With that, we are given a chance to her again. I think we'll go ahead the next presenter, sir. We have Saroj Kumar Thakur from Holy Family Hospital going to present talk about intravenous radiography.
Yes, sir. Good evening, everybody. Sir, I am from Holy Family Hospital.
You have a PowerPoint presentation, sir? Just
Yes, sir. Yes, sir. I have a PowerPoint presentation.
Yeah, thank you so much. Can you upload that before
Yes,
we
sir.
start?
Yes, yes. Just yes.
No problem.
Yes, sir. Sir. Just.
I think you had selected the screen. Instead of screen, you select a window. You can go to stop sharing, sir.
Okay, sir. Is it okay, sir? Hello.
Yeah.
It's okay.
Go ahead. Start your presentation.
Okay, sir. My name is Saroj Kumar. I am from Holy Family Hospital, senior technologist. My presentation is on intravenous pyelography. An intravenous pyelography is a special X-ray examination of the kidney, bladder, and ureters with the help of contrast media. It is also called intravenous urogram. An intravenous pyelogram can show the size, shape, and position of the urinary tract, and it can evaluate the collecting system inside the kidneys. It can be done as an emergency procedure without any preparation. Intravenous urography nowadays decreased significantly in recent years due to the replaced by CT urogram, ultrasound, and MRI urogram. It remains primary modality due to low cost. The indication is hematuria, calculus in urinary tract, tumors of kidneys, infection, congenital anomalies, suspected urinary tract pathology, to study kidney function, or post urinary tract surgery. Advantage: detailed anatomy of the collecting system, demonstration of major calcification, sensitive for acute obstruction, and low cost. Limitations: it depends on kidney function, do not differentiate solid or cystic lesion, require contrast media and radiation, time consuming, missing small stones, quality of a study may be limited by inadequate bowel preparation, swallowed air, or technical variability, inconvenience of a long filming sequence. Contraindication: contrast allergy, hepatorenal syndrome, thyrotoxicosis, pregnancy, raised serum creatinine. Preparation of patient. KFT, especially creatinine, to assess the renal function. The patient is given mild laxative, 25 to 30 ml Castrol or Dulcolax, 2 tablets, about 12 hours before the examination. The patient is kept nil by mouth after dinner and is dehydrated by stopping the fluid intake after midnight. Take informed consent. Procedure: a spot film is taken, including the kidneys, bladder, and urethral region. Contrast media injected intravenously in a prominent vein, mainly brachial or radial, in the arm. Test injection of 1 ml of contrast is given. Then the rest of the contrast is rapidly injected within 40 to 60 seconds. Then filming. The filming sequence are, first of all, preliminary films. It is the full abdomen film. It demonstrates bowel preparation, exposure factors, location of radiopaque shadow, stones, or any radiopaque artifacts. Checklist before injecting IV contrast. First of all, patient preparation. If patient preparation is poor, we can give re-preparation. Second, LMP, creatinine report. It vary in male and female. A consent form signed by adult relative, previous history of thyroid, asthma, drug allergy, or contrast reactions, and NPO after midnight, NCT or previous ultrasound previous report. Contrast. The dose varies in adult and pediatrics. In adult, it is 1.2 ml per kg. In pediatrics, it is 1 ml per kg. If creatinine level is slightly raised, not only creatinine is the parameter to check the KFT. So nowadays GFR is also used. And so in check glomerular filtration rate. If GFR is below 55, we should not inject contrast. If GFR is between 55 to 60 or near about 60, then we have to inject VCPAC contrast for IV, because it is non-ionic, dimeric, isoosmolar with hydration after injecting contrast, and safe for contrast-induced nephropathy. Above 60, we can inject Omnipac, Ultravist, or any other non-ionic contrast. This is the GFR chart. Between 60 to 89, it is mildly decreased. So we can give. Below 60, we cannot inject. Above 60, it is normal limit. Now, post-contrast film, after giving the in the contrast media, injecting the contrast, first of film is immediate film, or it is also called nephrogram phase. It shows the kidney areas. Next is 5-minute film or nephrogram phase. It shows renal pelvis, upper part of ureter. Then compression band is applied. It is now produced better pelvic axial distension. But some cases we cannot use compression band because of renal trauma, large abdominal mass, after abdominal surgery, or if a 5-minute film or pelvic calyx is not adequately opacified. Next is 15-minute film. It is also called release film. In this case, compression band is released. Then it shows ureter better. If it is not shown, then we take prone films. This position reverses the curve of the inferior course of ureter, making it antidependent to gravity. Next is cystogram phase or full bladder film. These all are normal films which is taken in IVP. It shows bladder size, contrast is filling the bladder or not, bladder surface is smooth or rough, is there any diverticula, filling defect or prostate. It shows. In some cases, we have to take additional films like prone films. If it not shows in 15-minute or release films, then we take prone films. If ureter not visualized in release films, both oblique films to project the ureter away to supine and to separate overlying radiopaque shadows. It is also used for visualization of posterior lateral aspect of bladder. Next is post-voiding films. It is for looking residual urine, bladder mucosal lesion, diverticulum, bladder tumor, outlet obstruction, or viewer. In some cases, we have to take delayed films. Taken between 1 to 24 hours. The sequence is 1 hour, 3 hours, 6 hours, 12 and 24 hours. It is used in case of obstruction where early nephrogram is seen but collecting system is not seen, or long-standing hydronephrosis in which renal parenchyma is seen but collecting system is not visualized. In IVP, there may be some complications due to contrast media, either minor reactions, it causes nausea, vomiting, mild rash, in intermediate reaction, I see only 1% extensive urticaria, facial edema, bronchospasm, dyspnea, hypotension, or severe reactions like circulatory collapse, pulmonary edema, severe angina, or some. Due to techniques, there may be some problem like upper arm or shoulder pain if IV catheter is not set properly, or extravasation of contrast at the injection site. After care, patient should be observed for 6 hours, watch for late contrast reactions, prevention of dehydration. If high-risk patient, renal function should be repeated. In some abnormalities, films which showing some abnormalities are pyloureteric junction obstruction. Next is horseshoe kidney. The film which shows in some patients there is a horseshoe kidney. The films like this, duplex ureter, or in some cases, non-opacified, partially obstructing uretrocele surrounded by opacified urine in the bladder, or full length shows distension of upper ureter. In case of
Thank you, Sarojji. Judges, please note
Yes,
that
sir.
this candidate presented within the time limit.
Yes.
Thank you, Saroji,
Yes, sir.
for the presentation.
Yes, sir.
Just wanted to know which technique will be better for IVP imaging, like X-ray based or CT based? And can you just highlight the advantages of that technique, CT based IVP or X-ray based IVP?
Yeah, nowadays CT urography is more used because of time limitation. But is IVP is more useful because we take sequence wise. Some cases in urography in CT, ureter is not visualized properly. So we cannot do repeatedly urogram in CT. If take plain films and then injecting contrast, and after 10 minutes we do in CT scan, and it does not give uh, full film. In film, if ureter is not visualized, we cannot do again and again. So in some cases, IVP is better, but due to low cost, IVP is better. But uh, in some cases, it is, if there is a time limitation, so CT urography is better because the bowel preparation is not so better. The CT urogram, we can see ureters or bladder, but in IVP, we cannot visualize it.
Okay. You might have heard about tailored urogram. Can you tell me what exactly it is? Tailored urogram or tailored urography. Most of the diagnostic centers these days, they are preferring this technique, no, to avoid radiation.
Yeah, this is the combination of different techniques. We, in this technique, we inject not directly all the contrast directly. First of all, we inject 30% contrast. Then we wait for 5 to 6 minutes, and then again give 40% or rest of the contrast, and wait for 100 seconds. Then we do the CT scan.
Okay. Okay.
So
Thank you,
that
sir.
okay. Thank you, Sergi. Thank you for such an opportunity to give me to present in ISRT. Thank you, everybody.
Hello. Hello.
Yes, sir. Yes, sir.
Good afternoon, Saroji,
Good afternoon,
and
sir. Good afternoon, sir.
thank you for the presentation. It was nice to hear. Just a few queries I have. Just I
Yes,
want to know that
yes, sir.
what are the use of laxatives for the patient preparation?
Yeah, person is to clean the bowel if any either fecal matter or gas. If gas is present, we give charcoal tablet.
Okay. So, do you think that the abdominal binder used is having any importance in the IVP?
Yes, sir. If we give abdominal binder, we do not give abdominal binder, then the contrast which we injected can rapidly go into the bladder. So we give the compression band to the person which have faster kidney function. So we cannot visualize pelvic calyceal system better. To see the pelvic calyceal system better, it is better to give compression band. And then we remove it so that the contrast comes into the ureter and bladder.
To enhance the nephrogram, and is it
Yeah.
having also having to remove the bowel gases from the area of interest?
Yes, sir.
Yeah, and what do you mean by the? You told that we are using the Visipack ISO osmolar in a
Yes,
certain range of GFR values.
yes.
What do you mean by the ISO osmolar contrast?
SMS, that is equivalent to body fluid level, body के जो electrolyte the electrolytes, body electrolytes have the same isoosmolar. It is the equivalent to body
The
hydro.
osmolarity should be in range of the blood in which we are
Yes,
injecting.
yes. It is equivalent to blood. So it is isoosmolar, so that it cannot give reaction any more reaction. It is safer. VC-pack is safer due to isoosmolar.
Okay.
Dimer, it is dimeric, so it is safe. Omnipack or Ultravest.
Do you know, is there any difference between the GFR values for the atrial contrast as well as for the venous contrast?
For the which contrast?
Venous, IV contrast.
Yeah, IV contrast and for
Atrial contrast. If someone uses for that.
yeah, GFR creatinine level may be raised, but we can give inject in adult patient. So GFR is better to calculate GFR in adult patient. If the person having creatinine 1.4, we can inject the contrast, because in this case the
Actually, the GFR terms refer for the glomerular filtration rate.
Yes,
And
yes.
for atrial contrast, it should be lesser than 60 and
75 Yes, 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 sir.
better than 45 ml per minute. So
Yes, sir.
from my side.
Yeah, for safer side, we use VC-pack. So to GFR is it is a, if creatinine is raised, we take another chance to check the GFR. If GFR is also less, then we cannot inject contrast.
Okay. Thank you, sir.
Okay, sir. Thank you, sir. There any more questions?
Thank you so much, sir. We will go ahead with the next presenter. I think we have today's last presenter, Mr. Gangadhar Gaddam.
Hello.
Yeah, I
Hi,
can
sir.
hear you, Gangadhar, sir. Can you
Yes.
share your PPT?
Yes, 1 minute.
He's from Star Hospital and he's going to talk about basic planning for cardiac MRI.
Yes, can you tell me my PPTs are visible?
It is
sir?
visible. It is excellent. You can start your
Good evening,
presentation.
everybody. Yeah, I'm starting now. Hello, can I start now, sir?
Yes, you're start. You can start.
Yeah, good evening, everybody. My name is Mr. Gangadhar Gaddam from Star Hospital, Hyderabad. I'm working as a lead radiographer and MRI technologist there. So I'm here to present basic planning for cardiac MRI. So then objectives. So we are discussing about the patient preparation and planning for the basic cardiac MRI. And why cardiac MRI will do? For myocardial viability, I mean, any scar is there, the location of scar, location of infraction in myocardium. So ventricular function, I mean, ejection fracture and volume, left ventricle volume. So we can calculate in this cardiac MRI. And myocardiopathy, like dilated, patient have dilated myocardiopathy and what you say, cardiac masses and pericardial disease and congenital heart disease also. So first, patient preparation for the cardiac MRI. So we need to take consent first, because of we are doing this cardiac MRI in MRI. So in MRI we have like magnet. So patient had any surgeries, any previous history, so we have to know. So consent is very important. And changing the dress. So patient has been changed to our hospital gown. And preparation of the chest, I mean, patient have any hair on the chest, so if we cannot connect ECG leads properly, so we need chest preparation also. And breathing instructions in cardiac MRI, this is very important, these breathing instructions. So because of our heart gives some motion artifacts, and this respiratory also gives some motion artifacts. So we need to control that respiratory artifacts. So the breathing instruction is very, very important. This is in better is in expression is the very, very important, useful for cardiac MRI. And prerequisitions, we need patient proper history and serum creatinine, because of we are giving gadolinium and GFR and venous axis. Sequences, cardiac pulse sequences. So we are doing gradient echo sequences and spin echo sequences, and phase contrast sequences also for the flow studies, and PSIR for delayed enhancement contrast. The PSIR means phase sensitive inversion recovery sequence. Gradient echo sequences. The gradient echo sequences are the white blood sequence, and this is very fast sequence. And this is used when cine, it will give cine images, and it's ECG getting images. Why we are doing ECG getting means the heart will give the motion artifacts, so we need to control that motion artifact. So we are doing in the with ECG gating. Spin echo sequences. These sequences are black blood sequences, and T1, T2 also spin echo sequences. These all are useful for the anatomy. Coil positioning. So patient is supine position on the table with head first. So we are putting coil, one anterior coil and the posterior coil. So in some centers they don't have specific for cardiac coil. So we can do with like this flex coils also we can do. And we need to give center laser light at the level of the mid chest. And ECG lead placements. So this black and this black ECG lead at the level of 1 centimeter nearby the episternum, and the triangle and white and this red is triangle between this our nipple, and black is the nearby axilla. The plans of imaging. In cardiac MRI, we are taking any, not in cardiac MRI, in any MRI, we are taking survey. Okay, that is for the planning perfect. It will give 3 planes like axial, coronal, sag. And again, we are taking like black blade or white blade, axial, coronal, sag. Because of the, we need to know some anatomy, and the patient have any like meds in the chest, otherwise any mediastinum nodes. So we have to see these all things. So we are doing like axial, coronal, sagittals also. And vertical axis, I mean 2 chamber view. Horizontal axis, I mean 4 chamber view. And short axis, and 3 chamber view. And perfusion study, phase contrast sequences for the flow studies. Already we discussed the PSR sequence for delayed contrast. And this short axis is very, very important. This is gold standard sequence, because of we are doing post processing and volume and this ejection fraction in this short axis only. Plan for 2 chamber. So plan for 2 chamber, we need some 4 chamber, one axial cut and one sagittal cut. In 4 chamber, I mean, we are this yellow line, our planning line. So we are taking one mitral, one image nearby the mitral wall and LV apex. So we are cutting like parallel to the mitral wall and the LV apex. So in some patients, we are unable to see in one image like this 4 chamber. So we need to scroll the images up and down. And in sagittal also, we are doing parallel to the left ventricle septum. So the in center of the left ventricle. So our 2 chamber will come like this. And in 2 chamber, we are seeing like left atrium and left ventricle also. For 4 chamber, for 4 chamber, we need like 2 chamber view and short axis also. In 2 chamber, we are cutting our plane line, mitral wall, center of the mitral wall and left ventricle apex. And in sagittal, we are including RV, left ventricle apex also. And in third image, I am avoiding some iota, because of that iota will give some artifacts in our 4 chamber. It will look like VSD or ASD. So I am avoiding that iota. So finally, we'll get our 4 chamber like this. In 4 chamber, we are seeing like right atrium, right ventricle, left atrium, left ventricle also. Plan for the short axis. So plan for short axis, we need 2-chamber and 4-chamber view. So we are cutting our plane lines parallel to the left ventricle. From mitral, we are taking at least 12 cuts and 8 cuts with 0 gap distance from mitral valve to apex of the left ventricle. I mean, we are covering total left ventricle. So finally, our short axis will come like this. So plan for 3-chamber view. Plan for 3-chamber view, we need one 2-chamber view and short axis. In 2-chamber, we are cutting my center of the mitral valve and second point at the level of the left ventricle apex. In sagittal view, we are including aorta now, because of in 3-chamber we are seeing like left ventricle outflow. So finally, our 3-chamber will come like this. Next, plan for perfusion. Same, how we are did short axis, like that only we are doing plan for the perfusion also. So our perfusion will come finally like this. So we are giving contrast at least 10 to 12 ml, depending upon our institute. Some people will give 10 ml only, some institute will give 12 ml, some institute will give 15 ml also. This is T1 Scott. This is post contrast sequence because this is like a look locker sequence. So this will give our time of inversion recovery timings. And in this, when you are giving the when you are given contrast after 7 minutes, we are taking delayed sequence. Before that, we are taking this T1 Scout. In T1 Scout, first image the contrast is filling, and second image so contrast is like it's filling, and in third image contrast is washing out. So in myocardium, where the nulling is black signal, I'm taking that TI value. For example, I'm taking 320, the TI value. So finally, we are getting this scar images like this. So where the contrast is there, that is the infarction area. Where the nulling is there, black signal, that is the normal area. So take a message. In these slides, we are discussing about patient preparations and positioning, planning for the chamber, post-contrast technique. And thank you. And thank you for ISRT because of given for this opportunity.
Thank you, sir. Judges, please note this candidate presented within a time limit. Now, the discussion or suggestion is open to the judges.
Thank you, sir.
Thank you, sir. Thank you.
Gangadhar Gaddam, sir, you have presented
Can you
very
exit
well.
your,
And
can you stop sharing, sir? Gangadhar, sir?
1 minute. Okay, okay.
Yes,
yeah,
no, absolutely fine.
sir, you have presented very well, and I feel it will be quite informative and helpful for many candidates who have like joined here.
Okay,
And
thank you.
quite knowledgeable it was. Practically, it was quite knowledgeable. I just wanted to ask you, sir, about have you heard about this double inversion recovery sequence, what we use for cardiac chamber imaging?
No, actually we had, but we are like we are doing some cases. We don't have that sequences like that. So we are asked all our applications and also. I think that is new sequences
Yeah,
for that,
exactly.
no?
It is bit new.
So that's so we don't know exactly about
Yeah,
that.
practically in many hospitals, this sequence is not yet installed. Just wanted to ask.
Yes, correct. Yes, correct.
Fine, sir. Thank you so much.
Yeah, thank you for trouble for Shashi sir, because of last time also I tried for presentation. Now I am in my own brother's marriage, so I'm giving this presentation in mobile. So thank you, sir.
Good afternoon, Gangadhar.
Yeah.
It was
Yes, sir. Tell me, sir.
it was a nice presentation, and it was very nice to hear from you to learn something new.
Yeah.
Congratulations to you also that you are presenting from your brother's marriage. So sweets are also there.
Yeah, sir. So,
So
frankly, I'm telling, sir, this presentation I'm learned from our Vimal Raj sir.
yeah.
Yeah,
So
Narayana Hridaya, I came 3-4 times for learning for cardiac MRI there.
okay. So it's
Before.
another good thing. Just one query I want to know that in your view, or what do you think, which
Yes.
one is the gold standard for cardiac studies, 2D ecography or the cardiac MRI?
Uh, 2D
How?
ecography is the good standard because of we will find no in cardiac 2D ecography only good standard because of it will give so much of information like masses also and LV ejection also LV volume also and so many information will go in that one. In cardiac MRI it will give like ejection fraction and volume also, but after that we will depend on 2D echo only. So our radiologist will ask like we need complementary of 2D echo, so we are getting some values here, so that values are correct or not, so they will discussion with cardiologist and they will do again 2D echo. So 2D echo is the better for viability. Anyway we are doing like cardiac MRI only.
Okay. Thank you from my side.
Yeah. Okay. Thank you so much.
Thank you sir.
Gangadhar sir.
Thank you sir.
I still remember on a second week he was not able to present it, but he came up with a very good presentation, I feel.
Yes,
Anyway, this
I'm
one,
telling now
my
I'm in marriage now.
association will not alter the marks anyway. So thank you so much. With this, we are going to end today's session. With this, before I'm concluding, I need to announce last week e-poster presentation on the topic of MRI. The winners list I announce now. The first prize goes to Samarpita Haldar from Institute of Postgraduate Medical Education and Research from Kolkata. Yeah. And the second prize goes to P. Ruby, Savita College of Allied Health Sciences from Chennai. So I congratulate both of the winners for their winning in the competition. And also I like to mention here there are very good presentation from the student side, and we had also very good quiz competitions through online. I feel one of the new kind of initiative done from the ISRT side, and just a zonal level competition it got over, and the result will be announced later. And all this winners list, everything, will have the closing ceremony in the next Sunday. I request everyone to join on that day, and we'll have a good session of some from the eminent guest speaker on that day, and the ending session of all our competition. And also I will announce on that day oral presentation winners also on that day. With this, Anto sir.
Yeah, Namaste Sashi, tell me.
Yeah, I request Anto sir to give a word of thanks, and we will end the session.
Just a minute, sir.
Yeah, please go ahead, sir.
Yeah, may I speak?
Yeah, please.
Yeah. Thank you, sir. I just want to congratulate all the participants, ISRT, sir, Daniel sir, and also like to thank the ISRT and the entire fraternities who keeping faith on us and keeps us learning and keeps us improving. We'll try to do our level best, sir. And last but not least, also the Shashi sir, so who takes the initiative. It's a tireless effort, and the ISAT is doing in guidance of Suresh sir, Anto sir, and Daniel sir. So from bottom of my heart, I would like to thank for the opportunity, sir.
Then I request other judges also to give a few opinion about their side.
Thank you, Mukesh.
Hello, sir. Hello, sir. Sir, good evening. Sir, good evening all. I congratulate all the participants today. Everyone presented very well and a lot of information they had given who are uh, from the YouTube people who are observing. It's good it is. Anyway, I'm glad to be a part of this program as a judge, and also heartful thanks to a sensational Secretary of ISRT, Mr. Shashikumar Shetty sir. And also I thankful to Suresh sir, Anto Ramesh sir, and Commander Daniel sir. They are supporting as a backbone for this ISRT. Actually, I'm the president of this Udupi Manipal ISRT Academic Club. As a president, I congratulate all, and it should be a success for not only this program, for all the programs. So I'm very happy to say thank you very much for inviting as a judge for me. Thank you very much. Thank you all.
Few words from my side also. Uh, Thank you for giving me this opportunity to judge the event. Uh, I got a lot of knowledge. In fact, many of the senior people have presented today, and it is a very good opportunity for everyone to hear from the very senior people in the field. Uh, Thank you, ISRT, for such a nice discussion, such a nice type of topics which were presented. And Mr. Shashi also. Shashi is quite close to me. He's always, actually, Shashi is a kind of role model for many people. Okay, he is really working hard for the ISRT as well as for the radiological imaging branch. Okay, so thanking you all, the senior members of ISRT as well. Okay, I think few of them are still here. I can see Antonio sir. Okay, thank you so much for giving me this opportunity.
Thank you all. Okay. Thank you, Shashi. As he said, it is very important, and you have taken a very bigger role for this event. And it is very difficult, but still you managed with your work, and we really appreciate you. And we are expecting such leaders in our team, because basically we are focusing on education, and that's what we, a very important thing I wanted to convey to everyone is you have to, as artificial intelligence, Dr. Vimal sir said very clearly about this, like that, like we have to leave footprints to our juniors and also for this professions. So I kindly request to clone Shashi, everybody like you, Mukesh, everybody, so that we get a lot of Mohit and Vishu, lot of people are there. It's very important that we get it together. Even in this pandemic, we get this opportunity online to get connected. First, we thought it will be very difficult, but like people like you all in the team, it made us very easy. So definitely, it is going to be a very successful for ISRT and ICRT. With everybody's leadership, we'll be able to excel. So our basic motto is to ensure that we do justification to the profession by teaching the people whatever we have learned, and also together we have to learn from them also, because I see a lot of juniors with very good knowledge at this stage. So it is all the credit goes to them and also to the professors who are leading them. So once again, I thank Dr. Vimal for his wonderful artificial intelligence presentation. And I got a lot of calls from different countries requesting to re-telecast that event, because Sir also shared a recorded session. I think it will be easy for me to redo that, and we will be telecasting it once again for the benefit of the radiographers across the world. So thank you once again all. Thank you judges for your precious, wonderful means judging. Also the time taken for you on this Sunday. So I thank all the leadership team, Commander Daniel sir, Suresh sir, Panneerselvam sir, everyone for on this occasion. And thank you Shashi once again. And thank you all for making this event very successful. And thank you for the participants. Without you all, we are nothing and we are not able to run the show. And thank you, everyone. We have a lot of other opportunities. Please encourage other team members and colleagues to participate. Thank you, guys.
Thank you so
Thank
much.
you, sir. Thank you so much.
Sir. And we all will see you again in the December 6th at 3 p.m. onwards. We'll have the closing ceremony, as well as all the winners list will be announced on that day. Thank you so much. See you some other day.